Good afternoon, everyone. Welcome. Thank you for joining us this afternoon. My name is Melissa DeMars, and I'm a behavioral health consultant with the Overdose Prevention Engagement Network, or OPEN. And we want to welcome you to today's webinar, Bridging the Gap, Practical Approaches to Sustaining Medication for Opioid Use Disorder, MOUD, Treatment from the Emergency Department to Long-Term Care. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address all questions as time permits during the Q&A portion at the end of the presentation. We're offering CME, Social Work CE, and McBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We'll also email the continuing credit information after the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and the reducing harms of substance use, with an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use. We work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts. They provide guidance for managing patients who have substance use disorders or complex pain, and who can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. Many of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all our credits also qualify for the DEA required substance use disorder training. We provide MOUD training for providers, and this year we're incentivizing primary care providers and advanced practice practitioners with $250 to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform prescribing. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events, and we fund implementation of permanent medication disposal boxes for qualifying applicants. We also provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. And finally, we offer overdose rescue support. We fund implementation of naloxone vending machine and distribution boxes. We also offer naloxone administration training. These trainings are offered in person or virtual and are free. You can access more information about all of these services more directly using the QR codes or by visiting our website. OPEN understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. Our behavioral health consultants, or BHCs, work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally through the state of Michigan. So I'm going to go ahead and introduce our presenter today. Dr. Erin Dorolaski is a full-time emergency medicine nocturnist at Trinity Livingston in Ann Arbor and is a part-time clinician and adjunct assistant professor at the Medical College of Wisconsin in Milwaukee. Further, they staff a safety net addiction medicine clinic at the Ingham Community Health Centers in Lansing, Michigan. They're a graduate of Case Western Reserve University School of Medicine and Bellevue Hospital, New York University Emergency Medicine residency, and completed their research degree and postdoctoral fellowship at the University of Michigan. They are currently a co-investigator on the Open Medic Take-Home Naloxone program, which is active at more than 40 Michigan hospitals. So we want to thank you for being here, Dr. Dorolaski, and I will turn it over to you.
Thanks, Melissa. I really appreciate that introduction. I'm going to load up my slides and we'll get started. So I think we already saw the title, Bridging the Gap, Practical Approaches to Initiating, Sustaining MOUD Treatment from the ED to Long-Term Care. So I have nothing to disclose. This is the requisite CME slide, other than the possibility that because I'm at home, my dogs may start barking if they see a critter. My apologies. So let's go over the objectives, what we're going to cover today. So first, we're going to define the importance of identifying and promoting a clinical MOUD champion within the ED, describe the importance of identifying and developing partners within your hospital system, outline ways to build a network of community partners. I will demonstrate how to create a procedure for referral to an outpatient provider. And then we'll talk about how to formulate a care plan when you're unable to do so. So I think you're all familiar with this graph, which I borrowed again from the CDC, looking at the trajectory of the opioid overdose crisis over the last 2.5 decades. The good news is in 2023, we finally saw a decrease, the kind of first significant one in the last 5 years. But we're still overall seeing a significant number of opioid overdoses in the emergency department. And unfortunately, a substantial majority of those patients are still not getting care for their opioid use disorder. So how did we get to this point where we're doing a webinar on how to bridge the gap between the ER and outpatient care, starting people on buprenorphine in the hospital during their acute visits? Well, it goes back to the 2015 randomized control trial that I think everyone's familiar with, which basically showed that starting ED buprenorphine, either giving people buprenorphine in the ED when they were in withdrawal or sending them home with a prescription if they weren't, after they were diagnosed with OUD, resulted in increased engagement in addiction treatment at 30 days and fewer days of reported illicit opioid use compared to patients who just got a referral or got a brief behavioral intervention and a referral. They also demonstrated a decreased use of inpatient addiction treatment, although there weren't any differences in urine drug screens or HIV risk behaviors. So this is 9 years ago that this trial was published. Where are we today? Well, my colleagues at the University of Michigan, led by Dr. Chua, looked at this recently using a large pharmacy database of patients who had been diagnosed with a suspected opioid overdose and were dispensed either naloxone or buprenorphine, and then cleverly compared those numbers to patients who were in the ER for anaphylaxis and were sent home with epinephrine. And you can see where the red represents naloxone and the green represents buprenorphine, with blue, the patients who got epinephrine for anaphylaxis. Only about 1 out of 13 patients with a suspected opioid overdose went home with Narcan, and only 1 in 12 were given a prescription for buprenorphine. So we're not doing as well as we'd like to nearly a decade after Dr. D'Onofrio's study at Yale. So why is that? Well, there have been a number of qualitative studies that try to answer the question, what are the barriers to making this happen? Well, regulatory concerns come up frequently in these studies. Physicians cite a lack of institutional support, a lack of experience with medications for opioid use disorder. And by that, just to clarify, we mean buprenorphine specifically, and then methadone as well as naltrexone, although the latter we don't start in the ER. They identify need for training, the lack of protocols, or at least protocols that are well integrated into the electronic health record, a dearth of counseling and support staff, and the need for a robust referral system for outpatient care, which we're going to talk about today. And then last, I think, a lot of us have been frustrated by the fact that we may start patients on buprenorphine, but we are lacking feedback on the patient experience, especially after they leave the ER. So luckily, some of the regulatory barriers have fallen. In 2019 in Michigan, for example, they removed the Medicaid prior authorization. Unfortunately, researchers found that this wasn't really associated with a significant change in buprenorphine prescribing among Medicaid enrollees. Importantly, I think Joe Biden signed off on getting rid of the X waiver on January last year. But again, here's Dr. Chua again, a New England Journal this year. Although they found that although there was an increase in buprenorphine prescribers, that didn't really translate into patients getting more buprenorphine or new patients being started on buprenorphine. So again, we're not seeing that these regulatory changes are being translated into meaningful increases in the number of patients with opioid use disorder who are getting treated with buprenorphine. So what does work? What are the facilitators? Certainly, we've identified a lot of barriers. Well, again, we have research on this. And what folks have found is that the way to get ahead, the way to engage emergency physicians and staff in improving these programs is to support clinical champions, which we're going to talk about, addressing knowledge gaps and biases through education and stigma reduction programs, integrating the non-medical needs, meaning addressing a lot of the social determinants of health that profoundly affect patients with substance use disorders, and then developing a capacity for warm handoffs. And we're going to talk a lot about handoffs. I'm going to disclaim that the definition of a warm handoff is when you have a transition of care between two providers in the same room as the patient. But a lot of what we're going to call warm handoffs are really where you have very specific date and times for patient care transitions in terms of appointments that are constructed and facilitating transportation, et cetera. So we'll get into that, but we're going to use the term warm handoff somewhat loosely. So let's talk about champions. So champions matter. There is a substantial amount of evidence in the substance use literature that having a clinical champion as part of your program speeds its implementation. It helps maintain these types of interventions like doing ED-initiated buprenorphine, and it enhances motivation and engagement of your care partners. Also, it's a great way to overcome a lot of systems barriers. These programs don't just develop from on high. You can't just create a mandate, although there are a number of mandates, including state level legislation and federal requirements that will continue to affect the type of work we do, treating people with substance use disorder in the emergency department, but you need individuals and groups of individuals to move this work forward. There's even data from the buprenorphine literature itself. Again, here we have Dr. D'Onofrio, where they found that engaging local champions, as well as protocol development and having a system for performance feedback, increased buprenorphine prescribing in the emergency department. So these interventions work. So where do you start? So I think the first place to start when you're trying to figure out how to bridge this gap is really to go to your medical director, because they're your most important champion and or you're the chair of your department, kind of depending on how your department is structured, or both. Importantly, they're going to help identify the players that you need to engage to make this work move forward. And importantly, they can help you direct you to the folks in suits. So we in pajamas who are trying to do this work really need to engage the administrators early on when we're trying to develop new buprenorphine programs, because there are a number of regulations and local policies that we may need, that may not be aware of. Hospital administrators may be able to help you identify certain hospital-based initiatives, grant funding, and I think critically, you need to engage them early on, because you're going to need to know what type of memoranda of understanding and referral agreements you're going to have with your local providers in order to transition your patients to outpatient care. The other thing I'll mention is that it's probably important that legal and risk management be aware of any new substance use initiative, because and I discovered myself, and I'll talk a lot about my own experience kind of trying to do this work in Lansing, you may run into obstacles because of the perception, even if it doesn't jibe with reality, the perception that starting people on medications for opioid use disorder in the emergency department is potentially risky. So next, it's critical, regardless of who you end up having as part of who is your champion or who is part of your team, you need to engage the leadership for social work, nursing, and pharmacy. And if you have a residency, I recommend engaging your residency director as well, because they will identify potential champions to help you motivate this work and kind of explain where some of the pitfalls might be to help you overcome them. So who are the potential champions? Well, I'm a physician, so I'm probably biased, and I've tried to do this work before. In fact, I spent a year in Lansing with a grant from the Community Foundation of Southeast Michigan, developing a program at Sparrow. But advanced practice providers, your physician assistants and nurse practitioners can champion this work. It's very reasonable to have a social worker, nurse, pharmacist, anyone who's like passionate and motivated and has the skill set to develop a team can champion these programs. I think ultimately it's important that you engage clinical folks in the ER who are going to have FaceTime with colleagues, because I think that on-shift advocacy and modeling are really useful. But I'm not trying to be, too biased about who should lead this. That said, it's got to be, you have to have folks who actually work in the ER. I think it's a little too challenging to try to do this if you're not working clinically in the emergency department. So I'm going to talk about some of the roles of your champions. First, physicians and APPs. So a lot of this, although we're not going to talk about the entire breadth of program development here, I think the way this gets started is you start with your protocol. And this involves a lot of work with IT. You've got to get your staff trained. And then again, we talked about on-shift advocacy, modeling, and developing a QA process, which we'll talk about a little later, and giving feedback to your providers along with coordination with your social workers, nurses, and pharmacists. So this is just a little screenshot of the ED buprenorphine protocol I developed when I was in Lansing, and I just wanted to point this out because I used cute little cow icons. Develop order sets. And in this case, it's a little hard to see, but there's a little red exclamation point because several years ago, they were still requiring us to attest that we had gotten our X waiver or we were prescribing within the 72-hour rules. Because again, I said, there are still a lot of concerns about the potential risk of using these medications. And then I don't have a copy of my EHR report, but I actually went to the IRB and got approval to really collect as much useful protected health information as we could, including PDMP access on these patients, because if you're not following these patients up, you're not going to have any idea how well your processes work. And then important shout out to Open because they were the ones essentially organizing and providing the buprenorphine training for acute care providers that I connected my staff with. So this is extremely useful. I even did a little teaching myself. And then, you may get the opportunity to send some emails following up cases to your colleagues when they put things like stop substance use as discharge instructions when patients leave after an overdose. And this one, just for reference, was from a 26-year-old patient who had 4 overdoses over the period of 6 weeks and then unfortunately died after this discharge. So pharmacy, whether you have a designated champion, you're going to have to engage pharmacy early on because they're the experts at formulations, how and what you're going to store. For example, at the Trinity sites I work at, we only use the Suboxone tablets, not the films. They can help making sure that patients discharged from the emergency department are able to fill outpatient prescriptions. And although this might be a high bar, they may be able to help advise community pharmacists because at least anecdotally, and there may be some literature to support this, although I think it's less of a problem, but I certainly had experiences where retail pharmacists were reluctant to fill Suboxone prescriptions for ED patients. If you want to develop a program where you have take-home dosing, again, you need the pharmacist, and they can help with staff training and QI. Nursing, obviously, instrumental to making ED buprenorphine programs work, especially with regard to triage screening, development and implementation, use of the COWS, the clinical opioid withdrawal scale, which a lot of programs are using as part of their triage screening process, meaning when someone triggers positive for an opioid use disorder screen, they will automatically get a number for you, and this can help you determine the need to start buprenorphine during the ED stay. They are obviously fundamental to discharge planning, medication safety, and they can help disseminate your protocols and help educate nurses, whether you outsource that to a consultant, kind of like we've often done with our naloxone program, and they also will do on-shift advocacy. And I think are important models of trying to change the way we talk about substance use disorders in the emergency department and using person-first language. And of course, they're part of the care coordination team. So I want to just highlight, because I think it's relevant to a lot of this work, and especially to nurse triage processes, that the group at University of Pennsylvania studied the implementation of a universal opioid use disorder screening, because a lot of emergency departments, especially ones that I've worked at and ones in our naloxone cohort, are just doing the kind of out of the box, typically EPIC electronic health record substance use screening, which is usually around just general drug, tobacco, and alcohol use, but it's not opioid specific. And they found when they screened everyone for opioid use disorder that it increased the number of patients getting these COWS assessments, it increased naloxone prescriptions, and also it, although modestly increased buprenorphine, it was statistically significant. And I think it's really important work that we've been asking this question for many years about whether we should do universal opioid screening, and this evidence suggests that it's probably meaningful. So I think last I'm going to talk about social work, which I think really are the social work is kind of the linchpin of any substance use treatment program in the emergency department. These are the folks who are going to coordinate with both your in-network and community-based programs. They may be able to provide brief behavioral interventions for patients with opioid use disorder and other substance use disorders. And critically, they can help with transportation, insurance issues, food and housing support. And often, you may have patients who are missed at triage as having complications of OUD, but I don't know how many times I've had patients who presented with suicidal ideation, for example. And then it turned out when social work did a behavioral health assessment, we discovered that they were, depressed and upset because they couldn't get treatment for their OUD. So I want to underline just the critical importance of addressing social determinants of health. This is another paper from the Yale group where they interviewed folks who had survived an opioid overdose. And in addition to identifying that negative treatment experiences and stigma by staff and just stigma of being on treatment were obstacles to getting care, they consistently identified the need for stable housing, requests for employment services. In fact, one of the participants in the study asked if the hospital was hiring, and then they pointed out a need for mental health care. So I think we often are because we're, as clinicians in the emergency department, we're often very like medication first because we want to be able to press a button, write a script, and fix things. I think this study really illustrates the critical importance of addressing social determinants. So how do we bridge this gap? This is what the talk is all about. For reference, I want to go back to what they did at Yale in the 2015 study when they started patients on Suboxone ED or prescribed Suboxone to take home. And they had a system where they basically had you got a primary care appointment that was going to do your first 10 weeks of Suboxone within 72 hours. You got take-home doses, and then you got 10 weeks of outpatient care, usually every week or every 2 weeks. And then after that, you were discharged typically to a community program or to like a private clinician or detox. And this model was obviously efficacious, but a lot of us may not be able to replicate this. So where do you start? Now, if you're in a system that already has addiction medicine specialists that take ED patients, then that makes it a lot easier. And you may not benefit as much from this webinar, but that would be, I think, that's the ideal model, right? But most of us don't have access to these types of services. And in fact, I would probably argue that although I know I'm talking a lot about what's published, the truth is that those are the experiences of probably a few dozen, mostly academic or academic affiliated medical centers in the country. But there's 5,000 other emergency departments who may not have these resources. But if you have it, connect with them. Psychiatry may be an option. And what I did when I was at Sparrow was I connected with one of the primary care residencies, in this case, family medicine, and they had already gotten all of their providers waivered. So we developed a system where essentially what we would do is we would, if we identified a patient we wanted to treat with Suboxone, we would page the family medicine resident who was on call in the hospital, and they would pass along that information to schedulers who would reach out to the patient. So you can develop systems, even in cases where they may not be doing regular prescribing. Suboxone has been around for a few decades, and the nice thing about it, in addition to its pharmacology, is that you can use it in outpatient settings. The other nice thing about partnering within your hospital system is that it makes it easier to create these kind of warm handoffs. You have a shared electronic health record, which facilitates data sharing and patient tracking. So, and then again, I want to highlight, I am obviously biased here, the fact that, maybe your primary care folks don't have as much experience doing Suboxone prescribing, and people often have a lot of anxiety around it. Open has this terrific program of consultants, as Melissa already highlighted. I've actually used them myself as an emergency physician doing MOUD work at one of our FQHCs. So I can't give them enough kudos. And really amazingly, they now have published data to support the fact that their consultants, webinars, and addiction medicine expert support actually have resulted in increased density of buprenorphine prescribing and the number of patients receiving buprenorphine prescriptions in Michigan. So again, kudos to them. So how about connecting outside of your hospital or network with community partners? So I'll kind of group these into two groups, the opioid treatment programs, which are your methadone programs, and then office-based opioid treatment programs, your OBOTs. And then there are other options. I mentioned FQHCs, where I currently work. And then telemedicine providers may be an option. And then kind of the last one, which we'll touch on briefly, are private practitioners. So where do you get started, like finding community partners? Well, I used a couple of just publicly available, somewhat random lists from my own region. One is from Michigan Medicine, and I have another one from Livingston County. And these are kind of maybe familiar with folks who work in the emergency department as examples of kind of the, I think classically, like the 13 Xerox stapled pages of community-based resources for people with alcohol and substance use disorders. And I think that, these will give you an overview about where historically you've been sending patients and who might be in the community. But I would really recommend always starting with your social worker, because these are the folks who are engaging our community partners on a daily basis and really know the landscape. So that's not a bad place to start if you are really starting from, kind of zero. There's a reasonably good online directory from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And this is very useful. And again, if you want to get started and just find out what's in your county or your city, you can find a lot of facilities here. The initial information is not terribly detailed, but there is an annual directory that they put out, the Drug and Alcohol Use Treatment Facilities, which is basically the survey results of all of the licensed facilities who respond every year. And this has extremely granular information about each program. And this is really important because if you're starting someone on buprenorphine in the emergency department and discharging them to longitudinal care, you obviously want to know if that facility even uses buprenorphine, because some places may not, or they may just use it for detoxification. And because at least probably half of your patients or more who are presenting to the ED with complications of substance use disorder are likely to have Medicaid, you want to know what type of insurance they take. So on the right, it's the font's a little small, but you can kind of see these are just some examples from Michigan studies. And they have, again, a lot of very detailed information about services they provide. This was actually data that we used a couple years ago. This is myself and my colleagues from Wayne State and Michigan State, where we actually mapped all of the emergency departments in the state and then compared them geographically to where these treatment facilities were. And what we found was only about half of the emergency departments in the state were within 10 miles of a treatment facility. So again, just to highlight, there are still persistent geographic barriers to care as well. People have actually studied the SAMHSA National Directory and found that when they called folks, a quarter didn't even pick up. Of the 3/4 that did, about 3/4 of those would provide buprenorphine, but only about a quarter on the first day, meaning you could send someone to treatment, they could get assessed, but they wouldn't necessarily be started on medications. And then about 10% referred out to other programs and 10% offered no therapy or referral. So this still, even when you have this detailed information on who is providing care in your community, it's still kind of hit or miss as to the likelihood whether you're able to connect people. So ultimately, you're going to have to do a lot of, if you don't have a partner already, and you need to bridge this gap, you're going to have to make a lot of phone calls, and sometimes it can be very frustrating. There is a buprenorphine practitioner locator who just identifies everyone who has kind of opted in to be in the directory and can prescribe buprenorphine. But this one can be hit or miss. I actually registered for this as well after I did the X-Waiver course. I'm not sure how useful that is. It is an emergency physician with no regular office, and probably underrepresents, according to researchers, the number of waivered patients in the DEA database, which is subscriber only. Also, they found that they're often difficult to reach by phone. I actually tried reaching out when I was developing the program at Sparrow to a number of folks who were in my region, according to locator, and I honestly wasn't able to contact a single individual. So another option. So I talked about federally qualified health centers. There are a number of these in Michigan. They have a mandate to provide substance use disorder treatment and MOUD care. It can be a little hit or miss. My experience is I actually partnered with them initially when I had the Community Foundation grant. And then what happened was we ran into barriers, and the barriers were that although the primary care docs got waivered, meaning they were kind of told they had to, none of them actually wanted to prescribe Suboxone. So that's why I ended up partnering with the family medicine department at Sparrow, because this kind of fell through. And then years later, they reached out to me to help provide addiction medicine care at their clinic, because still, 4 years later, they still don't have primary care physicians who are willing to provide Suboxone treatment. That said, FQHCs are great because they really provide wraparound medical home care, including primary care services, dental, behavioral health. Another option, and again, we use this as well, is telemedicine. The rules around telemedicine prescribing of controlled substances were relaxed during COVID, and they've kind of maintained that relaxed state since. I'm highlighting Work at Health because they're the ones that I partnered with during COVID when we were rolling out this program, and it provided another option for us while we were working through the challenges of getting an ED buprenorphine program off the ground. You may have reasonable concerns about telemedicine as an option because, a lot of our especially unstably housed patients may not have a phone at all or a smartphone, but there are actually a number of really interesting, even ED-based substance use studies where they've actually given people smartphones. And I'll tell you, relative to the cost of a finger laceration repair, let alone a CAT scan, a phone actually is pretty cheap and might be an option if you want to expand your outpatient access through telemedicine. I'm going to mention bridge clinics last. Bridge clinics are maybe a little ambitious. in terms of what you're aiming for. But these are either hospital or in some cases emergency department-based clinics that provide a kind of a transitional location where folks from the ED can get rapid follow-up. They're very low barrier, and they help with providing harm reduction services and linking long-term care. But again, most of these have been developed at places where they have pretty richly resources substance use treatment programs. But the literature suggests that they have really fantastic impact on patients and providers in terms of encouraging them to do this work and making them more empathetic. So next, let's talk about the referral processes. So warm handoffs really aren't likely to happen in person, although there are exceptions to that. But what we talk about mostly when we're talking about doing ED warm handoffs to outpatient providers, is that we actually have a specific day and time, meaning we have an appointment set up at the time we're seeing the patient, in which in cases like this, where essentially like someone is sending either encrypted message via the electronic health record or via email or maybe a fax. And ideally, the handoff is really warm, where you may have a peer coach or care navigator come to the emergency department, see the patient in person, meet the ED provider in person. And then, like, for example, my colleague in Detroit, who does emergency and addiction medicine, actually had a program there who would literally pick patients up in a van, take them to the pharmacy, get their prescription filled, and then take them to the facility. So this is in contrast to the kind of colder handoffs, where you may do like a fax referral from the emergency department, but the patient needs to reach out to schedule their appointment, or maybe they're just given a phone number or an email or website for a telemedicine provider, or even in some cases, just a physical address that takes walk-ins. So in terms of developing your handoff processes and your referral agreements, I gathered information from this. This was a study of a clinical support decision instrument that was done at Yale. And they queried folks from the hospitals in their research study about what these warm handoffs should look like. And the consensus from the qualitative research was that, when you're developing referral agreements between your hospital and your outpatient treatment providers, that it's important to delineate mutual expectations and responsibilities, define what information is necessary, both for and after the referral, because it involves a lot of PHI, and then have mechanisms to help patients through the referral process. Ideally, you want to develop processes that don't impede the clinician workflow, right? Because in the emergency department, you have your nose bleeds and GI bleeds and head bleeds you got to care for, and you do not want to be calling facilities yourself. And as we mentioned, you need to protect patient privacy and then facilitate quality assurance and QI processes. What are the important variables you need to identify when developing these mechanisms? Well, one is how does your referral work, right? Is it by email? Is it by electronic health record message? Do you use the same software or scheduling platforms? Because as we said, if you have an in-network provider, you may be able to schedule patients directly during the ED stay. What demographic and other PHI do you need? Then critically, what days and times can patients actually be scheduled? And again, we talked about this with regard to the SAMHSA directory. Do they actually use buprenorphine or other medications for opioid use disorder that your patients want to continue after discharge? So just to kind of put some of this together and illustrate illustrate some options or different models for handoffs to long-term care, I sketched out 3 different ways of doing this, kind of from cold to most warm, where the cold model is basically the patient, after being started on ED buprenorphine, just gets like a paper copy of referral sites, maybe highlighted or circled with their ED discharge instructions. There's no transportation, no access to peer coaches, and there's really no mechanism for follow-up. So that's the coldest model, and we're going to talk a little bit about that in a moment before we wrap up. Next, there's the warmer model. This probably is more similar to what I used when I was at Sparrow, where we basically would send a fax with the UDS results or leave a voicemail, or in my case, we paged the family medicine resident who would leave a message with the scheduler. We didn't have any transportation options. We, when I started, had peer coaches through a grant, but then that program was discontinued. So by the time we actually got our buprenorphine program started, we didn't have them available anymore. And all of the follow-up I did was mostly through the PDMP, looking to see if patients that actually filled their prescriptions. Then there's the kind of ideal deluxe warm handoff, where you get a direct appointment scheduled, or if it's off hours, a direct message to the scheduler, and they return within 24 hours to the patient to provide them with the day and time of their appointment. They may have transportation either during the ED visit or shortly after discharge to take them to the facility for care, and they have peer coaches, peer recovery coaches, or care navigators who see the patient in the ED and do an actual warm handoff in its most literal form. And then you have connected EHRs or program reports where information is shared between the emergency department and hospital providers and your outpatient program. And then, relatedly, putting this together, I sketched out again 3 models of ED-initiated MOUD care to kind of give you a feel about how this might work and what you might kind of be aiming towards. So in model 1, it's just a standard triage screening, your kind of modules from your electronic health record that are typical. The providers typically identify these patients by chief concern or through their HPI. No consultations are available. And then you give them maybe a week of buprenorphine and then a list of community-based programs that they are responsible for calling themselves. In model 2, again, you have a few more options. In this case, you may have a best practice advisory that blinks based upon the patient's chief concern or prescription history or visit history that tells you, hey, this is a patient who may have complications of OUD. They get a nurse-driven COW score at triage. They have the option to get social work consultation if social work is available, a buprenorphine prescription, and then you may fax referral to the community-based opioid treatment, the OBOT, and they will follow up with the patient. So that's, I think, model 2 is kind of like where we want the floor to be ideally. And then, of course, there's the third model, which is, again, the deluxe one, where everyone gets screened for opioid use disorder. You have social workers who may be able to do brief behavioral interventions, case managers, peer recovery coaches in the emergency department. They may only require fewer days of 3 days of buprenorphine because they already have an appointment scheduled. And I mentioned this briefly, but I'm going to give a shout out to doing methadone in the emergency department, which you can start. Usually the typical protocol will be like 30 milligrams, and then you can actually bring them back for 2 more days of 40 milligrams a piece. This has been described by Dr. Wolfson in Vermont. And then you get a warmer handoff to a hospital-based addiction clinic, as an example. Or if you get started on methadone, you get next day follow-up or follow-up within 72 hours to an opioid treatment program. So those are 3 ways of kind of envisioning how this might work. Again, I want to underline the importance of doing QA. You need to set up processes where you can get weekly or monthly reports that look at your BUP administration and prescribing, and that tracking ICD-10 codes related to opioid visits, and also following up on ED return visits for opioid-related complaints. There are opportunities to develop case reports that you can discuss with your team, and I really recommend, if you're going to do this work, that you make these things standing items at your monthly emergency department meetings and create some system for audit and feedback. So last, how do you formulate a care plan without a designated outpatient treatment provider? This is the kind of bridge to nowhere phenomenon. Well, the first thing I'd say is that given the mortality associated with opioid use disorders and for patients who present to the emergency department with a non-fatal overdose, any amount of buprenorphine is potentially life-saving. So even the risk for ED patients who survive an opioid overdose of dying within 48 hours after discharge is about 1 out of 400. So it's not trivial, especially when multiplied by the number of patients we see. So I would say, even if you're not sure they can find anyone to see, you should still consider writing a script. And, having been doing this for a while, I would have no qualms about reviewing the PDMP and writing for 2 weeks if I needed to. Providing them with that your substance use resource list that you invariably and are kind of obligated to have in the emergency department. And then even trying to send them to primary care. I know, as I mentioned before, a lot of the primary care docs are reluctant to continue Suboxone prescribing, but I think I would reach out to any possible resource I could, give them very explicit instructions to return, because I'd much rather have patients come back to the ED in withdrawal after running out of a buprenorphine script that I wrote them, see one of my colleagues, and hope that maybe we can provide better care the next visit than not give them any treatment at all. Because not treating these patients who show up in opioid withdrawal puts them at such significant risk of fatal overdose after discharge. And then, of course, all these patients with OUD should get a naloxone kit. To summarize, identify interdisciplinary clinical champions. You need to solicit buy-in from your admin. The more you integrate your protocols in the electronic health record, the better they're going to work. It takes a lot of work. I spent about a year doing this with a grant to try to find linkages with outpatient partners, and it was very challenging, but ultimately we were able to do it. And then in order to keep these programs afloat, to maintain the work and to improve it, you've got to build in quality improvement processes. And then the last thing I'll say as a reminder that MOUD saves lives, prevents overdose, improves treatment retention, and reduces ED return visits. This is a summary of my references in very small font. And if you want to take down my contact information, I know this is kind of a bit of a fire hose of information about how to make these programs happen, but I am more than happy to respond by text or email to your questions or concerns if we don't get to them after I finish.
Thank you so much, Dr. Dorolaski. Really appreciate you being here. Very good information. Before we move on to the question and answer, please notice the continuing education credit information on your screen. You can scan the QR code by using the camera option on your phone, or you can this is how you access information about obtaining your credits, or click on the applicable link in the chat. This also will be emailed to all attendees today after the webinar. So if you have any questions for Dr. Dorolaski, please type them into the Q&A function at the bottom of your screen. You can click on that, type your answer and hit send, and we will read them out loud.
I think one thing, Dr. Dorolaski, just while people may be thinking of their questions and putting them in the chat, is sometimes finding a clinical champion is really difficult and it seems like either make or break a lot of quality improvement projects and initiatives in hospitals. Do you have any insights or tips of wisdom for those who may be struggling to find that right person to lead this work?
So, I mean, as I said, I think my initial advice is, first talk to your medical directors, then maybe talk to your kind of folks in charge, your nursing supervisors, your social work supervisors. And then the other thing is sometimes you got to go to the department chair or medical director and find some incentives. Because sometimes people may not be, I think champions obviously function the best when they're, intrinsically motivated, but sometimes there are ways to offer extrinsic motivation. And for physicians, at least, which is the group I'm most familiar with, there are ways to, basically by giving a modest amount of buy down or to help contribute to your bonus pool. So I think sometimes if you can't find anyone who's willing to step up voluntarily, because this does involve many hours, then I think the next thing is you have to consider the possibility of doing some extrinsic motivation.
Well, thanks again, Dr. Dorolaski. Was that any last party thoughts on what you put it on?
Okay, well, hopefully I preemptively answered everyone's questions since there's not much happening in the Q&A, but thank you everyone again for, thanks to Open Team for inviting me, and thanks to everyone who joined on the webinar today.
Yeah, thank you for being here, and thank you everyone who joined us today, and have a good rest of the day.
Bye.